Moving on to the fireside chat portion. So we have until 1:28. So it gives us about 20 minutes to talk through the landscape of digital mental health technology and how we can move forward. So my first question is pretty broad. From your perspectives, we think about the different roles of people in science and technology developers and investors and policymakers. What do you think is the role of academia, the public sector, and the private sector in creating this ecosystem where digital health technology can really improve mental health? So obviously, we tend to work in silos, and the points of connection can sometimes be the places where a technology dies that's potentially quite promising. So, maybe starting with you, Dan, what do you think about the roles of these different areas in creating an ecosystem for mental health technology?
Yeah, no, thank you. So, with respect to, I think the academic sector, I mean, generally, academic health centers have the patients, right? They're treating them, they're managing them, they're understanding what works, what doesn't work, on the front lines. And again, I think that the adoption of technology, let's kind of bookmark that for a second, because academic health systems historically may have not necessarily have been the most early adopters of technology, right? But again, they understand the evidence basis. They understand outcomes for patients. And so there can be a great breeding ground, as it were, for new technologies and new approaches to therapy. I do think it's important for, academic health centers to partner with, entrepreneurs and, kind of commercially driven operators in the market who have lived in the market, again, who have sold into each of these, kind of channels. And have, I think, those war wounds and those scars. They've learned those hard lessons about how you commercialize behavioral health technology. So I think there's a great opportunity there. And then finally, the public sector, our regulatory bodies, I think, are super important to, justify reimbursement, right? That if you are able to deliver a product or service that has a certain amount of evidence basis, that actually has the propensity to drive real outcomes, there should be reimbursement for that, because that leads to sustainability, right? If you don't have, revenue, they say, margin drives the mission. It's really, really hard to reach your goals and reach, large populations if you don't have all three of those entities all working together.
Yeah, thank you. So what are your thoughts, Pat?
Sorry, I muted myself. So academia can play a lot of different roles, I think. And, being in the academic side, I can, I agree with a lot of what Dan said. But, I sort of feel like there's two really important roles that academia can play. One is, in all the research I've done on digital mental health, I very rarely create the digital tool myself. I have either partnered with a company, or I've partnered with somebody else who has like a prototype that they want to test. And so what's great is that I don't really have any stake in the game, right? And I can be a really good, independent evaluator of the service or the product. And so one big role that academia can play is to provide that evidence base, particularly for real novel interventions that somebody might need for regulatory processes or to sell to health plans or whatever. So that's a real, fundamentally, if we're scientists, that's what we do, and we should do that. We can add that to the mix. The other role, like I haven't done this myself, but one of my colleagues from UCSF, Adam Ghazali, is a really good example of, how academia, can inform, a business. He had done a lot of work on, coming up with behavioral interventions for cognitive control deficits. And so he created this therapeutic video game. And when it was in his lab, it was a super scrappy, kind of early prototype. But the data were so strong as a targeted intervention for for a condition that cuts. His interest was in healthy aging, but there's been, like, I've been looking at it for targeting a subtype of major depression that is non-resistant to that is resistant to antidepressant medications in older adults, and it's the same neurocircuitry and all of that. But what he did was to kind of, I think he was approached by venture capitals and And they invested and took the tool, and this is now Achille Interactive. And so it's sort of like that handoff, like he did all of the proof of concept kind of early, like this is there's a target here and this is a mechanism. And then the company took it and did the commercialization end of it, which is something academics can't, I don't think, can do very well.
Right. So, following on from that, Pat, I think both of you spoke about engagement and, user interface design and adoption as major, major barriers to the use of digital health technology. And as academics, I think that's not, when you're thinking about evidence and, does something work, thinking about adoption and thinking about user interfaces doesn't tend to be a central part of the considerations. And I think it should, but, it's tend to be neglected. So you can imagine we develop something that we think works and we have research data to show that it does something good. And then there's a point of transition to a company, but something in the middle where there's that missing design component. And does it change the validity? Does it change how well something works when you change the design? And Pat, having been someone who's worked in that area yourself, how do you think about the way those two pieces interact?
Well, it would be really nice if when we're doing even the early prototyping, we're also doing the user-centered design stuff, because if we design something that nobody is interested in using, then you've just wasted your time. And I think that has been a challenge, like outside of technology. I have said this before, and it's not necessarily a popular opinion, but our psychosocial treatments are not very well adapted for the typical frontline clinician. So that's one of the reasons, not the only one, but it's one of the reasons why if you're a patient looking for, say, CBT or problem solving treatment, you're going to have a very hard time finding a therapist who can actually do it. And part of it is the engineering and the design of the intervention. It just doesn't fit, how people actually work with their clients. It was designed in the 1950s, like 50 years ago, and for a very different culture, very different patient population. But the same is true with technology. Rather than developing something that we think is cool, but we've never even asked end users, is this what they want, is really a mistake. And I think also the assumptions, like I alluded to this in my talk, that just because somebody doesn't use an app after 2 weeks means that, this assumption that it didn't work for the patient isn't accurate. I think it really depends on how the person used the app, what they got out of the app. And I do think that there is probably this cyclical utilization pattern, although they may not cycle back to the original app, but they may cycle back to something like it. And we need to better understand what people want from technology in their mental health recovery.
Right. That's a great point. And then Dan, you said something that struck me that for many cases for commercialization, it's more important. Adoption is more important than the evidence base. So, and of course, I think as a scientist, I don't want to hear that. The evidence base is the most important thing. So again, this tension between, how well it works and how much it's used, speak to that a little bit more. That would be great.
Yeah, no, it's a real truism. I think as an early stage investor, I've stopped trying to predict what patients will like and what they don't like. I just say, show me the data, right? Show me the data that they're using it, and that they have sustained engagement over time. I think that's been, the holy grail and the last mile of digital health. We have such thoughtful, talented technologists and mission-driven entrepreneurs who are building these great tools. It's really hard to get patients to use them, right? It's just hard, right? And I think there's a lot of reasons as to why that is. And you can you can recruit IDEO and have the best user-centric design focus, but you're still going to get 5 to 10% utilization, right? So, and I think a lot of it has to do with understanding the patient journey, understanding where they are, in their kind of clinical trajectory. I think it's understanding what their life looks like, what their ecosystem looks like. And I think where we've seen the most success is, of course, you want to have great user-centered design, you want a great usability, but then partner with entities that have generated trust with that patient, right? And so it could be a clinician, it could be a community health worker. Rarely is it the insurance company. I think we've learned that. But find someone who's kind of generated that rapport, that trust with that patient, and use that entity as the deployment mechanism of a great product.
Right. This concept of trust and rapport, I think, is something that came up in your talk too, Pat. Like, I think we I've heard sort of the idea of universal design, right? So universal design principles, things that work for everyone. But on the other hand, everyone often ends up excluding the groups that have the greatest health disparities and the most needs. So when you think about the intersection of design and trust, how has that, informed your work? How do those things link together? If that makes sense.
Yeah, is that for me?
Yes, yes.
Yeah,
Sorry.
I
You
mean,
can't tell
so
how I'm looking at it.
yeah, a lot of it is actually working with the communities and working with partners in the community who have that trust, right? So that takes a long time. Anybody who does community-based participatory research will tell you it can take a couple of years or more to for an investigator, somebody like me, because we carry a whole lot of history and bad baggage with us. But for instance, there are a lot of organizations that are very invested in helping the mental health in underserved communities. So, for instance, like Mental Health America, does have that trust, and they actually do a very good job of vetting who they work with. And so, I think it's that, like, really being clear that when you're sitting down and you're trying to figure out what the mental health needs are of the community, that you're actually hearing them, that you've got partnerships with organizations that will help you with deciphering what you're hearing too, because sometimes we hear one thing and we have our lens on it, and we need people to kind of correct us and say that's not what was being told to you. It's actually this thing that's a challenge. So yeah, I think giving the community voice, over time they can start to trust, and not abusing the trust. That's the other thing too. It's just being really careful with what you do with the information that you gather, making sure that they're involved from beginning to end, not just to collect information.
Right. So the elephant in the room always these days, I think, is COVID. Well, everything in the last year. I feel like COVID is just the beginning. So COVID, the Black Lives Matter movement, the political divisiveness in the United States, like all of these changes in the economy, wide-scale unemployment. How has this changed the landscape of the need for behavioral health technologies, the investment in them, and how we grow those technologies? Maybe we'll start with you, Dan, for this one.
Yeah, no, it's a great question. I think that there are three big impacts. The first, as you described, there's increased need. There's increased stressors. We already had a behavioral health access crisis, and by removing the ability to get in-person, treatment, and then thinking about providers that weren't necessarily ready, had not yet adopted telehealth. Just exacerbated, the need for behavioral health care. I would say the second, I think big change that I think COVID, had driven was as I flagged earlier, the government kind of stepped in and changed reimbursement rules around telehealth. Medicare, for example, for one reason or another, had a real challenge, and ultimately getting reimbursement, not even at parity for in-person visits, but just reimbursement period. CMS was really dragging its feet. And because of the pandemic, overnight, you had not only reimbursement for telehealth, you had reimbursement at parity, right, with in-person visits, which I think was a real incentive for providers to adopt, and ultimately, continuing to try and hit that access problem. And then I'd say the third is just, increased awareness from the payer community, right? Again, you can have CMS, paying for things, you can have providers saying they're important, but if commercial payers, have not yet, number one, understood, but number two, implemented, kind of new payment models and adoption for behavioral health care technology, it's really hard to get traction in the market. And I think, self-insured employers, I've written about this before, we're early adopters. I think perhaps even, more so than payers were. And so you had this widespread awareness of large enterprises willing to, kind of shell out real dollars for, novel and new forms of behavioral health care therapy for their populations.
Yeah. What do you think, Pat? What are your thoughts on the last year?
Yeah, I mean, I would agree with Dan that it really changed the landscape pretty quickly. From a reimbursement perspective, although I think that was temporary, to make those allowances permanent. We have historically, I mean, there's obviously greater need because of the consequences of COVID, the social distancing consequences. And it's demonstrated that people will use these digital mental health tools, not just for mental health but for healthcare as well. An interesting impact it's had is on clinician willingness to do telemedicine, because for a long time there's still has been historically a lot of resistance to doing therapy like this, that it's not the same, you're not in the room with the person. This belief that it hampers the relationship building that's needed to gain that trust to work with a patient. And from what I hear from my colleagues who are cheap, like who run clinics and all of that, that when they had to move to telemedicine, suddenly there was a transition. Like the providers had this aha moment that actually people show up for their appointments more regularly, they seem more engaged, and that yes, there's still that cost, but the cost is really on the therapist side, not so much on the patient side, and that there's a lot of benefit to doing care this way. So fingers crossed that we continue down this road, because there is a real potential for reducing disparities in this way.
Right. So keeping the good parts of the last year, even if we
Yeah.
lose the bad parts. Right. So this is a question that comes from the audience for you, Dan. So let me see if I can digest it. It's an upvoted one too. So how is FLAIR addressing the issue of understanding the user, patient, client perspective and what they want from behavioral health app if the funders are driving the vision? So these lenses are quite different if it lacks a focus on the outcome from the individual. So that tension, what do you think?
So is the tension between large enterprises like payers and providers and patients? Is that the question?
It sounds like the question is about, there's the user, patient, client perspective and what they want versus what the funder, the provider, payer wants. And does that result in a different vision? How do you bring those together? And how is FLAIR investing in a way that, hopefully brings those together?
Yeah, no, it's a really great question. And again, I would say that's probably one of the major reasons why you generally have low utilization and adoption of digital health tools that have been purchased, right? They've been purchased and paid for by large payers and large providers, and then they try to push them to the population, the patients, and they don't use them, right? And so I do think that there is a clear disconnect there. And again, when we talk about commercialization, I would have to say that in order to make the initial sale, right, you need to be able to convince the customer, the large enterprise, that there is value. But in order to make the repeat sale for renewal, right, you need to be able to show real impact, right? And you can't have impact if you don't have adoption, right? Ultimately, these large customers are generally looking for cost savings, not always, right? There are other ways that you can deliver a return on investment, ROI, but usually it's cost savings, right? And so, if patients aren't using your technology and your service, it's really going to be hard to drive those cost savings. And so you may have made the sale for year one, but when year two comes around and they want to renew, you may not make that, that follow-up sale, that renewal. And so, I think it's important to understand the customer value proposition. And then you have like a year, as it were. If utilization is low and adoption is low in the first, few months, you have to iterate, you have to, A/B test, you have to kind of, double click and try to figure out, like, how do we drive adoption in this population?
Right.
And it's not something that is unique to behavioral health. I'd say it's all of digital health and all of healthcare tech.
Right. Yeah, that's excellent. Thank you. So in the final minute of this session, so just final words, if you had to give one piece of advice to people who are developing digital health apps for mental health or commercializing them or whatever, so, what's your main takeaway, that if someone remembers one thing from this, what would it be? So we'll start with you, Pat.
I would say, like, have a better understanding of your customer base, and like what they want out of it. We do an awful lot of in psychiatry, we do an awful lot of design without of everything without talking to our patients. And if you want long-term adoption, we need to have a better understanding of how these digital tools are fitting into the patient's framework of recovery.
Yeah, such an important point. Thank you, Pat. And how about you, Dan? What's your one takeaway?
I agree with Pat's. I would add, study solutions that are in the market today, right? Understand how you're different, understand where the gaps are, and understand what the value associated with solving those gaps are.
Yeah. Terrific. Thank you both again for your great talks and for your time today and taking the time to chat and talk through these issues.